Good afternoon. My name is Jan Brunson, and I'm happy to welcome you to our session. We'll be talking about maternal health in South Asia, moving beyond maternal mortality rates. Here with us today is Pallavi, and she'll be from Oxfam. Oxfam India is one of the sponsors, as well as Youth Key Awaaz. And Pallavi will be saying a few words about our goals today.
Thanks, Jan. So Oxfam India is organizing. Thanks, Jan. Oxfam India is organizing this Google Hangout in partnership with Youth Key Awaaz to raise awareness and talk to the general public about the issue of maternal health. As we all know that in India, maternal health is an important issue. We have our women dying during the natural process of childbirth, and not only dying, women who survive are also left with lots of illnesses as a result of poor care during childbirth. So Oxfam India has been working on the issue of maternal health in a very focused manner in the last 3 years. And we are organizing a South Asia consultation on maternal health from tomorrow on 5th and 6th of February in Kathmandu, where we've brought in maternal health experts from the South Asian countries who will deliberate upon what has worked in the South Asian context, what has not, what is the unfinished business, and how we can take it forward. Before that, we thought it would be apt to have a Google Hangout and interact with the public here. And in terms of South Asian countries here, we could not get everyone at this point in time. So we will be talking more about 3 countries, that's Afghanistan, Nepal, and India. From Afghanistan, due to logistical problems, we could not get someone based in Afghanistan to join us for the Hangout. So we have Dr. Linda Bartlett, who Jan will introduce shortly, who has kindly agreed to represent Afghanistan based on the work that she's been doing in Afghanistan. Thank you, and now over to Jan to take the process forward.
Thank you. So it's my pleasure to introduce our panelists today. We have Dr. Linda Bartlett, who is from Johns Hopkins University. She's a medical doctor and epidemiologist with over 25 years experience in clinical and public health practice. She specializes in maternal and perinatal health. And her career has spanned from Health Canada, the U.S. Centers for Disease Control and Prevention, and UNICEF. She's the principal investigator of a large maternal mortality study in Afghanistan, a survey to assess the quality of facility-based maternal and newborn care in 7 countries in Africa, and a multi-country research study in South Asia to develop a tool for CHWs to identify postpartum sepsis. Dr. Bartlett's interests encompass 2 main areas: assessing and improving the quality of obstetric care in facilities, and developing and testing interventions that can be used in community settings. Next, I'd like to introduce and welcome Dr. Rajani Vaid. She is from the National Health Systems Resource Center. And Dr. Rajani is currently advisor, community processes at the National Health Systems Resource Center, providing technical support to the Government of India's National Health Mission. She's worked for over 25 years with grassroots NGOs, governments, donors, and private foundations in program implementation, evaluation, research and policy formulation in the area of health systems strengthening women and children's health and nutrition. Her special interest is the study and documentation of scaling up innovations from small-scale NGO and government-led pilots to district and state public health systems. She conducts seminars and workshops for scaling up training. She has a degree in medicine from Madras University and a master's in public health from Harvard University. Next, I'd like to welcome and introduce Ms. Pallavi Gupta from Oxfam India, who you met. And she's currently working as program coordinator in health at Oxfam India. And she comes with years of experience in public health advocacy and programming. Pallavi has a master's in social work from Tata Institute of Social Sciences, Mumbai. Since passing out of TISS in 2002, she's worked in the field of public health in Delhi, Rajasthan, Gujarat, with different NGOs, and she's been active in Jan Abhiyan, the Indian chapter of the People's Health Movement. Over the years, she's been involved in a variety of work, such as direct field implementation, action research, and policy advocacy. Her work has helped her in understanding the field situation in India, as well as the larger socio-political environment, leading to presentations and publications in national and international fora. And last, I'm Dr. Jan Brunson, professor of anthropology at University of Hawaii, and I'm a medical anthropologist specializing in reproductive health and population studies. I have a PhD in anthropology from Brown University, specializing in reproduction and women's health. And I believe that is all of our participants, so welcome. Thank you all for joining us. I'd like to start with a couple of questions. We'll have approximately 4 general questions for our panelists today. And the first question to start us off is simply, can you briefly describe the current situation of maternal health in your country of interest? And Linda, would you like to begin?
Sure. Thank you so much, Jan. So as Pallavi mentioned, I'm here representing some information on Afghanistan because unfortunately none of our Afghan national colleagues could join us on this forum, and so they kindly asked me if I could assist. So in Afghanistan currently, the national skilled birth attendance rate, that is women delivering with either doctors, nurses, or midwives who have midwifery training, is 40%. And that ranges, however, from in the cities up to 80% of women deliver with a skilled attendant, but it's as low as less than 10% in rural and remote areas. So it's still very challenging for women in very remote areas, of which there are very many in Afghanistan. The maternal mortality ratio has been recently estimated by the UN as about 400 deaths per 100,000 live births, and that's in a range they estimated of 220 to 750. So it's still quite a range of death risk that occurs, and that's about 1 in 50 women who is delivering is estimated to die in her lifetime over her number of pregnancies and risk of death. So about 1 in 50 women in her lifetime who is fertile and has pregnancies and gives birth will die in her lifetime of a pregnancy complication, which is a lot. But there has been a lot of progress in the past decade, and I think we'll be talking about that next. Thank you.
Thank you. And Dr. Rajani, would you like to comment as well?
Sure. I'm going to talk about India, equivalent to several countries. In the last decade, we've also seen tremendous progress in the country. And part of the progress has been related to, I think, political commitment, first of all. It wasn't there, and I think in 2005, with the new government in place, and the need to make an impact on critical issues related to women and children, a commitment to maternal mortality was made, and several health systems reforms were initiated. This ranged from infrastructure to expanding human resources to providing cash transfers to women to enable them to come into institutional deliveries, and to create an overall supportive environment in terms of health systems strengthening. And so we succeeded then in reducing the maternal mortality from about 254 to 167 in 2013. So that's the rate of decline, which has been pretty significant. However, in India, we also have the challenge of a very diverse situation. So we have some states where the maternal mortality is about 60, and some others where it is about 300. So we have this range across the country, and in many cases, it's not just a matter of health system strengthening, because we're still constantly struggling with high fertility rates and poor family planning, high unmet need, limited access to abortion, despite abortion being legal in India, limited access to blood, limited access to skilled attendance, gender inequities, and inequity related to caste and class. So in essence, part of it is to do with health system strengthening, but part of it also has to do with a lot of the social determinants, which I think we will be coming to later. Though fundamentally, I think we've sort of reached a point in the road from which there can be no turning back. Critically, in terms of women choosing to deliver in institutions. Institutional delivery in India increased from 40% in 2005 to almost about 75% today. However, there are issues with institutional delivery, and I think quality of care is something that we are battling with now, as I suppose is the case in most countries in the region. So I'll stop there and wait for you to sort of get the next question.
Thank you. Yes, we've already started to address the next question, which is what progress has there been in recent years? Linda, would you like to follow up?
Mm-hmm. Sure. Well, since the opening of Afghanistan in 2002, there's been enormous efforts, as probably pretty much everybody knows, with the government having a much stronger role and being able to expand services dramatically with the assistance of international donors and also technical assistance. So one of the really important things that was done in Afghanistan, which can be a model used in other countries and is a model actually being used in other countries, is the development and huge expansion of midwifery education. And this has resulted in the number of midwives being probably over about 4,000 now. I don't know the exact number as of this year's graduating class, but about 4,000, and it started at about 450 in 2002. And the midwives are spread across the country and more concentrated in certain areas where it's easier to access geographically and also due to being secure versus insecure. But the midwives are throughout the country, and so they provide women with a skilled attendant who, and they're also a woman and a woman's advocate as well. So it's been a very interesting process in seeing them as role models for other women in Afghanistan for education and employment. So the maternal mortality risk has declined in Afghanistan significantly and substantially from what's estimated to have been about 1,600 to, as I mentioned, 400 with a range of 200 to over 700. And so that's a huge reduction, and they're described as making progress towards the MDG goals, which are for maternal health, reduction in maternal mortality by 75% by 2015. And that's true of all the countries in South Asia that all are making substantial progress towards this very ambitious goal, which is really quite remarkable, I think. So contraceptive prevalence has increased also dramatically, and use of antenatal care, women's education, more women are being educated and also more girls are being educated, and all those things lead to reducing the risk of maternal mortality overall.
Thank you. And Rajani, would you like to comment as well for the India situation?
Sure. And as I started by saying a little earlier, we've seen dramatic declines. I think this is a complex of factors, really, and part of it has to do with increasing education, increasing empowerment of women, but I think substantially the change has been in opening up public health facilities. Government investments increased dramatically in the last 10 years, and were targeted to strengthening public health facilities or government-led facilities. The second major thing was involvement or in hiring huge numbers of contractual doctors and nurses. So India added 3 times the number of workforce that it had, admittedly contractual, not all of them are regular, but despite that, this huge influx of human resources in public health facilities made women feel that it was safe for them to come into hospitals. The third major thing was from hardly any ambulance services. We have about a fleet of about 4,000 emergency transport referral mechanisms, which we call the 108, and which promises to take a woman to a hospital within 30 minutes of calling. and by and large, this is met. Yes, in hilly terrains, it's hard to do, but this has made a significant difference to women's being able, at no cost, this is cashless, and women are able to be taken to public health facilities. The fourth major thing was this cash transfer of about 1,400 rupees. So I guess converted to dollars, that would be about what? Pallavi, you'll have to do the calculation for me while I talk. But so this entitled women, enabled women to come into the health facilities, and all services are provided cashless. And therefore, she's able to take this money back home, and it means a lot. For poor families, the sum of 1,400 is a significant amount. The fifth major effort was to create a cadre of community health workers that did a lot of other things, but one of them was to motivate women to come to institutions. And that has also helped increasing institutional deliveries, and therefore we hope reductions in maternal mortality. Couple more things. Care protocols. So Pallavi tells me it's about $23. That's about the amount of money women get to deliver in institutions. Instituting care protocols, guidelines, and standardization of care, which enable rapid scale-up of both training programs as well as adherence to protocols and quality standards in hospitals, is also been, it hasn't moved along as much as we would have liked, but certainly has moved quite a bit. And family planning, improved access to contraception and reducing unmet need has, that total fertility declines also contribute to reductions in maternal mortality, but overall strengthening of health systems has brought this about. So that's basically how far India has moved and why we've seen these reductions in maternal mortality. There are some gaps left. Is that the next question, Jan? Should we wait for the what?
Let's see. Yes, that will be the next question. That will be covered then. Okay, thank you. Would you? Yeah. Did you have anything to add, Pallavi? Or
we can go with the gap.
Okay, let's start with the gaps then. Please keep going.
Okay. So I think there was one more problem, which was adolescent pregnancies. In India, I think 20% of girls continue to deliver before they're age 21, and I think we see the highest mortality in that age group. And this is more concentrated in some areas than it is in others, and it's clearly linked to women's status. It's linked to female education, and these are issues that the health system alone cannot hope to address. And I think that's where the recognition of the action of social determinants, caste inequities, and gender inequities play a huge role, and that's not likely to go away by just strengthening the health system. The second major issue, I think, is quality of care. Yes, we've expanded coverage, but quality of care is a major, major issue. It often is a deterrent for women to come into hospitals. Even having delivered their first baby in an institution, some women say they would not come back to that institution for a delivery. So clearly that's an area of concern for us. I think the third major concern is this: we haven't been able to rapidly enough scale up skilled birth attendants. We do have a cadre of frontline workers called the auxiliary nurse midwives who were provided with some training, but it's too slow and too little to help, especially in the last mile districts, where access is really a huge problem. Despite the emergency transport, despite the referral linkages, we've not been able to do skilled birth attendant. Not like what I heard Linda about Afghanistan being able to scale up midwifery. We've not been able to do it in India. There is also resistance. Professional privileged doctors are not very keen on having nurse practitioners, nurse midwives, the way it's been done in other countries. I think we still face resistance there. Fourth issue, I think this issue of blood is an important one. We don't have blood storage centers or blood banks everywhere. We have another department that deals with HIV/AIDS, and their blood safety norms are so stringent that it doesn't allow for unbanked blood transfusions, and I think that's a major area of reform that we'll have to address, because too many women are dying for want of blood. So those are really the big gaps in the areas that we'll have to move forward if we are to sustain or bring these gains down, because India is not going to achieve Millennium Development Goals, which is a 109, which we're not going to get to by 2015.
Thank you for the summary. I'll just repeat the question then for Linda and Pallavi. So the original question was, what can the general public, community, and government do to improve the situation? Or in other words, what are the gaps? Linda?
Thank you, Jan. And Rajani, I thought that was an excellent summary, and there's clearly a lot of common issues across the countries in South Asia and even in developing or low-resource countries around the world. We face many of the same problems. So in Afghanistan, quality of care is also an issue, like it is virtually everywhere. The large urban hospitals face overcrowding. There are too many deliveries for what the resources can allow, and despite the healthcare providers' efforts, they can't pay adequate attention at times to each woman. And then the other major problem is the still continuing lack of access to care for very remote and rural populations. And this includes insecure areas in the south where women and their families are especially afraid to move at nighttime to a facility. So it's sort of lack of access, and then when there is access, in some places and ways, quality of care could be improved. And then overall, something that Rajani also mentioned is women's status in society, which is linked to the education that they're allowed to attain and can attain, and employment outside of the home. These are all linked together in a woman's ability to make decisions for her own health care. In Afghanistan and in many places, it's still a patriarchal society, and the woman must have the permission of her husband or her mother-in-law to seek care. And so that can also limit women's ability to access care, and is a gap that we hope to address.
Thank you for that, Linda. And Pallavi, would you like to add anything?
Sure. Just to add to what Rajni was saying, another thing that I think we have been missing is recording of maternal deaths, reporting of maternal deaths, because when in our work also we realized that the maternal deaths that we had picked up in the field, the maternal deaths that we picked up in the field, they were not recorded in the government, they were not there in the government record. And reporting is an issue because the health service providers are also scared that if they report maternal deaths, then they may be penalized that in their areas these deaths are happening. So this is an issue that the civil society has been advocating for. And the maternal death audits have been made mandatory by the government under the NRHM. But not everywhere is that happening, and it's not looking at the social determinants of maternal death. Like Dr. Rajni was very rightfully saying, it's not only the health system strengthening, it's also the social determinants aspect which needs to be addressed. So reporting of maternal mortality, when we talk of mortality, I think is an important issue that we also need to keep in mind, that our data is showing it is reducing, but are there also gaps in our reporting? Having said that, just to highlight the role of the community in improving maternal health, which is what Dan's question is, the work that we've been doing over the last 3 years in 6 states of India, Bihar, Jharkhand, Maharashtra, Chhattisgarh, Rajasthan and Odisha, has been with the community-based monitoring approach, which is also part of the NRHM, the National Rural Health Mission, wherein the communities become active citizens and take charge of the health services in their areas. So there is a village health, sanitation, nutrition committee, which is formed at the village level. So we've been working with these committees, activating them, strengthening them, training them to take control. So they work closely with the frontline health workers, the ASHA workers which were introduced as part of the NRHM, the Anganwadi workers, the auxiliary nurse midwives. So they work closely with them to monitor the services in their areas. They get an untied fund from the National Rural Health Mission of 10,000 rupees a year. So how to use that untied fund? And the communities are now demanding what is their right, and the rate of institutional delivery has increased, as we all know. The role of community has been very, very vital in improving maternal health, as we are seeing in our experience. While government is doing its bit and needs to do more, the role of community is also very crucial in this, because the family has to take the woman for delivery, the family has to take care of the woman, and there has to be a general active action on the part of the community to improve the maternal health. And which is why we've also been addressing some of the social determinants like girl, adolescent, marriage, early pregnancy, where we've had instances of girls now refusing to get married. Once they were brought together in a group, they got the support of the VHSMC, they have said that they don't want to get married. So there are examples where girls' marriages were fixed and they were about to get married, but they refused at the last minute, and the whole village then convinced their families to say, okay, let's not get them married right now. So those kind of issues will have to be tackled at the community level. And apart from that, the another issue is of the nutrition of women. In India, nearly half the women are suffering from nutritional anemia, which is also a big indirect cause of maternal death and morbidity also, not only death but also morbidity, which is another issue that we are still, I think, struggling to handle. We have certain food security programs as part of the public distribution system, but some of these gaps are yet to be filled. I'll stop here for now.
Thank you. And I think we've started to address some of the medical issues, some of the technology issues, but in all the panelists' comments so far, they keep coming back to the social determinants of health as well. And that is, in fact, our last question to discuss. What are the important social determinants of health that need to be addressed in order to improve maternal health? And as you noticed, that these issues were already underlying our panelists' responses so far. So I think it's definitely something we all recognize. Let's see, Rajani, would you like to start?
Sure. I touched upon it earlier, but I think in India, status of women is really a key concern about why maternal mortality should continue to take place. Part of it is health systems, I agree, and some states, which the state with the lowest maternal mortality in India, Kerala, has a maternal mortality of 61. It's a matriarchal society, women are highly empowered, there's 100% female literacy, and the health systems function perfectly well. So here's a conglomeration of circumstances that allows that to happen. But we have several other states in which there are access barriers, but there are also issues of women's status. And these access barriers don't work for women in very different ways. Their cultural access, their financial access, and even though a family might be well off, a woman's access to care for maternity still remains low. The second major issue is girls' education. We still have high dropout among girls at secondary school level. So girls simply just stay home after class 8 or class 10 and get married early. So early marriages, early childbirth, and there are several schemes that the government has now begun to implement, which is to provide incentives to women and to health workers to motivate them to space babies. That's also an issue. Many people are concerned that this kind of incentivization of spacing is not really such a great idea. It leads to coercion maybe. But be that as it may, the fact is that, I just spent a little bit of time talking about family planning in India. We're restricted to sterilization, female sterilization particularly. And the burden of family planning falls on the women. We have limited choice for women, and that also leads to the linkage with maternal mortality is pretty well known. The other problem, I think, is this whole issue of caste and marginalization of particularly large groups. For instance, tribals in India have a very hard time, both because of geographic access and cultural and financial barriers to seeking care. That is also a reason. Geographical marginalization, I think, plays a really key role. We don't recognize it often enough. It's also a reason why we cannot have human resources posted in areas, particularly women, because too often in India, women want women to help them deliver, and that also is an issue is a geographical access barrier. So I'll stop at that since I already talked about it before.
Thank you. Pallavi, anything to add for the India context?
Yeah, Rajni already talked about the family planning issue and the lack of safe abortion services.
Sorry. Dr. Rajni did talk about the lack of safe abortion services in India. Just I'll take 30 seconds on that. The abortion in India has been legal ever since 1971. I think we were one of the first countries to legalize abortion, though that was done from more of a population control point of view. But so far, we do not have women can access safe abortion services. The technologies that are followed are also not the new ones, the manual vaccination or the medical abortion services. Those are not so frequently available. There's problem of over-the-counter availability of medical abortion drugs, of unqualified practitioners. So women are accessing abortion services which are not necessarily safe, which leads to mortality as well as a lot of morbidity. which is why we've also titled this hangout as Beyond MMR, because apart from mortality, there are all of these issues are also adding to women's morbidity and the quality of life that they lead after some of these experiences in their life. So access to abortion is something that as a policy issue and as a program implementation issue, I think in India we really need to take up along with access to contraception.
Thank you. I'll just add a couple of words about Nepal and the social determinants as well, just because there have been some interesting studies coming out of Nepal in the past 5 or 10 years that actually show that the involvement of men in pregnancy and birth will prove to help women give birth in an institutional setting, or otherwise at least with a skilled birth attendant present. And it's kind of surprising given, you know, the patriarchal setting of many of these countries, but I'd at least like to voice that in the Nepal scenario, we've had several studies now saying we need to get men more involved in birth. They need to know more about it. They need to learn and be educated more about pregnancy and the situation of their wives. So I'll just add that to the mix of social determinants in the recognition that women aren't acting fully independently in these settings. They are, you know, they're members of families, and they're working within a social and cultural context in which they're not acting independently. They're acting as a wife, they're acting as a mother, as a daughter. So I'll just add that to the discussion, and then ask Linda if she has any other comments on the social determinants for Afghanistan.
Still on mute, sorry. I actually don't really have anything more to add that's different from the things that I had already mentioned briefly, and what you and Rajani and Pallavi just spoke about very nicely. I think there's many of the issues are in common across the country. So while South Asia has very diverse countries within it, there's also common issues that I think it's wonderful that Oxfam India has convened this meeting to look at what the common issues are and if we can work together somehow to try to address them. So, thank you.
Thank you. Any other remaining comments that our panelists would like to add before we move towards closing?
Jan, may I?
Please.
So I think one of the dangers of reducing maternal mortality is complacence, in a sense, because as maternal mortality begins to decline, policymakers and programmers may just sort of say, okay, so we are getting there, and that kind of complacent setting will take away resources that were completely invested in maternal health. So I think there is a bit of a danger of that one. The second, I think, is this professional privilege being a barrier to allowing task shifting. That is also an area of concern, because if we don't scale up midwifery in India, it's very unlikely that we're going to be able to come to to reduce maternal mortality across the country, not just in a few pockets. And the third major concern for me is maternal morbidity. We know neither the quantum of morbidity now, nor I think much of it is related to quality of care. But in a sense, we've been, and I think at this stage where we had to bring down maternal mortality, maybe this was the way to go. But I think we will have to begin to look at maternal morbidity, because there are studies that say for every one death, there's about 50 to 100 morbidities happening. But really, that's the tip of the iceberg, and we don't know too much about it. So I would say that increasing political commitment and keeping the light on maternal mortality is going to be critical for the next 5 to 7 years. And then thinking about research into maternal morbidity, how women present, where do they go, all of that is unanswered. So,
excellent point. Excellent point. Any other comments? Yeah.
That's very good. This is related to what Arjun was saying, that India is equivalent to several countries, which is why I think in terms of policy and program in a country like India, there are few things which would work in that manner of one size fits all. While we may have a central policy or a central guideline for a program, but we really will have to leave it to the states, and states will have to take it up based on the local needs. Even within states, we have districts which have different geographies, which have different requirements and different challenges. Even in a state like Rajasthan, you have desert districts, you have hilly and tribal districts. So that approach, I think we will have to change. We often have the center deciding what the states should be doing, how things should be implemented. But this is something which will have to be left. It is being done. There are district plans which are made, but they don't necessarily work out the way they are envisaged. So in effect, we often have same thing being rolled out all across. And this is also important with respect to diversity in terms of some states having reduced the MMR, some states not having reduced the MMR. So that difference also we will have to keep highlighting that there are still states which need increased investment, which have still not achieved where 178, the figure of maternal mortality ratio indicator in India, may be misleading for a large part of the country. Not to miss that point, and or letting people make local, state-specific, district-specific plans and programs.
Thank you. Linda, do you have any closing thoughts on future hopes, future?
Well, one thing I wanted to also add to the conversation is that in addition to maternal mortality and the need to also understand and monitor and prevent maternal morbidities and injuries like obstetric fistula, is the impact of on the family when a woman dies. We haven't talked about that very much yet today, but there are scientific studies that have shown that if a woman dies from childbirth-related complications, the infant that she's carrying at the time has a much higher chance of dying as well if they're born alive. And even her older children have a higher chance of dying and a lower rate of education. So there's a large health and social impact on the family from a woman's death. So the mother is integral to the family, and some people believe that the mother being integral in the core of the family, and the family being the core of the community and a healthy society, it's imperative that we prevent maternal deaths. But I think that what we also have acknowledged today but need to recognize is that since the MDGs were convened, there's been enormous progress globally, and we need to congratulate our colleagues who are out there in the field and implementing the programs and delivering the babies and taking care of the mothers and the babies, and the governments who are putting together policies and strategies, including the Afghan government has been wonderfully proactive and supportive of women in reducing maternal mortality. So there's been progress globally, and we need to keep the attention going in order to get the situation as good as it can be.
Thank you. So I guess I will just recap some of the highlights of our discussion in closing. Thanks so much to all of our panelists again. So one of the themes that came up was increased reach and some of the progress made in terms of increased public health facilities, including increases in workforces and things like ambulances, which are absolutely critical in transport. We discussed cash transfers and the assistance that provides, and a increase in institutional deliveries as well. We touched on some gaps and some places that we can still improve. And then again, we highlighted the social determinants underlying all of this, and including things like education, contraception, and improving the situation for women across the board, and of course the role that poverty plays, and social hierarchies, which is class and caste. Any closing words or thoughts, or shall we say thanks to everyone and wrap up?
Since Jan has given the opportunity, just one thing. I want to remind you of what Linda was saying about congratulating our colleagues who are working in fields like that out there that they can deliver, which I think is so true. And which is what we also acknowledge in the India context, and maybe also other South Asian countries, that we have doctors, nurses working in very, very difficult conditions. The places where they live, the facilities in which they work, they may not be the best, they may not get all the infrastructure, but they're still providing the services that they can. Their own lives may not be as comfortable, their families
may not have all the facilities that we may want in our lives, and because of which not many people want to go into the rural areas. So I think thinking about the human resources and how to make it feasible for them to live in rural areas where there is the most critical need is also important, rather than only bashing the health service providers that they don't do enough, but we also need to provide them the support system to be able to live there and provide the services. Thank you.
Okay. Okay, well, in closing, I'd like to thank all of our guests, our panelists, Rajani, Pallavi, and Linda. And I'd like to thank again Youth Awaaz for sponsoring, as well as Oxfam India. And thank you all for joining us.
Thank you, Jan. Thanks, Linda. Bye.
Thank you.
Thanks all.
Thank you, everybody. Pleasure.
Bye.